Good morning, good afternoon, good evening, wherever you are. I'm very happy to be with you today talking about the management of myelodysplastic syndromes, as well as the most important updates from ASH 2022. I'm one of the myeloid experts focusing on both AML and MDS at Yale University. And this is my email, this is my Twitter. Feel free to reach out for any questions you might have. So these are my disclosures. So the outline I will talk about today is updates in terms of MDS classification, updates regarding the MDS prognostication, updates in the management of both lower risk and higher risk MDS. So I will go over the standard approaches and the clinical management and how do the new updates from ASH 2022 fit in, especially in everyday practice. So the traditional way to diagnose MDS continue to depend on morphology. Dysplasia is a very important aspect of assessment of myelodysplastic syndromes. However, there has been important recent changes to the way MDS is diagnosed based on the WHO classification. I think one important change is, as you can see, for the persistent cytopenias, the cutoffs actually were made a little bit less restrictive, meaning that hemoglobin is now less than 12 for women and less than 13 for men. And it used to be less than 10. And for platelets, it's less than 150. And it used to be less than 100. The ANC remained at 1800. So you have to have one at least of those three lines. And the fact that these are less restrictive will probably lead to more cases diagnosed of MDS that in the past did not meet the cytopenia cutoff for MDS. The second, I think, important area is the importance of excluding other conditions that can give you cytopenias. And you can see a list of some of those, including nutritional deficiencies, medications, other comorbid conditions. And of course, the bone marrow evaluation, which is still important, and you still cannot diagnose MDS without a bone marrow, not only to show the dysplasia, but also to look at the blast count and to assess the cytogenetics and the molecular abnormalities. Now, dysplasia is still important in the diagnosis of MDS. However, with certain cytogenetic abnormalities, you are able to diagnose MDS right now. And I'm showing you some of those, like 5q deletion and monosomy 7 and complex karyotype. However, what we realize is that beyond the cytogenetic abnormalities, oncogenic gene mutations are very important in MDS. More than 90% of patients with MDS will have at least one mutation. Most of those patients, basically, even the ones who do not have any cytogenetic abnormalities, which is around half of the patients with MDS, most of them will have at least one molecular abnormality. The median generally per patient is around 2 to 3 mutations. And you can see a very long list of mutations. There are more than 40 of them. They are recurrently abnormal, they are somatic, and they occur with different frequencies, as you can see in the table. However, the problem in MDS is that only a few of those mutations, 5 to 6 of those mutations, occur in more than 10% of all the cases of MDS. So it's not a homogeneous disease like CML, where you have PCR-able in everybody, and that has implications, of course, for the prognosis, for the natural disease history, but also importantly for the treatment. Generally, the more mutations you have, the worse the outcomes. And the realization, the importance of those molecular mutations, their impact not only on prognosis, but also on the phenotype of the MDS has led to integration in the classification systems in a more prominent way. So many of you are familiar with the WHO classification. You can see the previous iterations to the left. The WHO classification started in 2001 when the MDS was formally recognized as a malignancy. Before that, we used to have the FAB classification, and we have several iterations of the WHO. The last one before the 2022 was 2016, which was the revised 4th version. The 5th iteration, which just was published in 2022, occurred at the same time when there was an update from the International Consensus Classification. So we have 2 classifications now for MDS. One of the issues is that those classifications, while they agree on a significant number of areas, there are some divergence in how MDS is diagnosed. For example, now the WHO is calling MDS myelodysplastic neoplasms. So formally, it's included neoplasm in the name. However, the abbreviation continues to be MDS. The WHO removed the difference between single lineage dysplasia and multilineage dysplasia, which was present in prior classification, while this was maintained in the ICC. Both classifications included genetically defined entities. We used to have deletion 5q. Now we have two other molecular entities based on mutations. One is SF3B1, and that incorporates most of the cases with ring sideroblast. However, the WHO still maintained an MDS with ring sideroblast if the SF3B1 was wild type. While this was not included, there is no MDS ring sideroblast in the ICC. It's called MDS non-otherwise classified. So it's purely genetically defined based on the presence of the SF3B1. Another difference is that ICC uses a cutoff for the variable allele frequency of 10% for all of their mutations. So the SF3B1 has to be more than 10%, which is not present in the WHO. TP53 mutation, both entities recognize that patients with TP53 generally do poorly, and they integrated this as a distinct subgroup of MDS. In the WHO 2022, this is called MDS with bi TP53 or biallelic TP53 inactivation. And this supersedes any other diagnostic category, including the presence of TIL5Q and MDS with SF3B1. Importantly, both alleles have to be abnormal. The ICC also uses TP53 to diagnose TP53 mutated MDS, but the ICC also included a new category when the blast count is more than 10%, 10% to 19%. This is called now MDS/AML, while the WHO 2022 still referred to this as MDS with increased blast. So it used to be excess blast, now it's called increased blast, 10 to 19%. And lastly, the WHO included two categories that were not previously included, which is MDS, hypoplastic MDS, and MDS with fibrosis. Because of the recognition of the worst outcomes with MDS with fibrosis and the distinct natural history and potentially different management for hypoplastic MDS. However, those entities were not included in the ICC. And lastly, both categories have accepted formal definitions of CHIP and CCUS. The definitions are largely overlapping, but this is important because we used to struggle in finding even disease codes for these. Now we have codes for CCUS. And importantly, AML, in both conditions, AML can be diagnosed based on molecular alterations and certain translocations. So for example, if you have NPM1 mutation, that will diagnose you as acute myeloid leukemia, regardless if the blast count is not more than 20%. However, there are minor differences in the blast cutoff, and this is a simplification of the main differences. However, I think there are significant differences, and the field is trying to figure out what's the best way to reconcile these, because now we are in a situation where some patients might receive different diagnoses, not only MDS subtypes, but also is it MDS or AML? And that importantly has significant implications, not only for counseling and treatment, but also it can confuse patients, it can confuse providers. And I think there is a significant push to try to harmonize these two systems as soon as possible so we can all speak the same language. One of those efforts came from the International Consortium for MDS, ICMDS. And you can see I tried to sum the entire abstract in one slide. So the first thing you can see to the right is that both the ICC and the WHO classifications are prognostic, meaning when you look at the overall survival according to the subtypes, you can see significant separation of the curves. And the best prognosis, as expected, is for MDS with SF3B1 mutations. And the worst prognosis is for MDS, especially high-risk MDS with TP53 biallelic alterations. So I think both of those findings were expected. However, I think some of the interesting findings of this analysis, which used the Moffitt Cancer Center database, more than 2,000 cases that were molecularly annotated, and they were recategorized according to the WHO and the ICC classifications. And I think what some of the important findings is that patients with MDS multilineage dysplasia had worse outcomes than single lineage dysplasia, suggesting that we indeed should keep the number of lineage dysplasias rather than removing it as per the WHO. And at the same time, that the blast count more than 5% correlated better with OS than more than 10%. And I think that's important because I think MDS with excess blast generally, in many ways, should be approached as a single entity in the absence of certain genetic alterations. MDS with fibrosis was verified to have poor outcomes, and MDS with TP53 alterations also was found to have the worst outcomes, and the TP53 status was an independent predictor of survival regardless of other factors. And of course, these data are from a single center, but I think they provide a roadmap for hopefully harmonization of the two systems. And there are ongoing discussions and efforts looking at that, including further validation in multi-center data sets within the International Consortium of MDS. So going beyond classification, I think the next step is prognostication. Once you diagnose MDS and classify the patient, you are trying to decide whether the patient has lower or higher risk MDS. There is significant difference in the outcome and the management, and it's still currently dichotomous. While different tools like what you see here, IPSS, revised IPSS, WOPSS, and MD Anderson score can give you different risk groups, very low, low, intermediate, high, and very high. Practically, you always end up with one big group or two big groups, sorry, either lower risk or higher risk, because generally the treatment is similar. Now, the groups that has the intermediate risk group, such as the IPSS revised, the intermediate risk group has been a bit of a challenge for us in deciding how to manage the patient more as lower risk or high risk MDS. So there are different ways to do that. The most common way is to use the score of 3.5 within the intermediate risk as lower risk, and to use the scores of 4 and 4.5 within the intermediate risk as higher risk disease. However, importantly, none of those scores were developed to be dynamic except the WHO score. And none of them, as you can see, included any molecular alterations or accounted for comorbidities. However, as I mentioned, it's the intermediate risk group, which is a substantial number of patients in the revised IPSS, could behave as lower or higher risk MDS patients. And I'm showing you here 4 different ways to do that. But as I mentioned, the most common way is number 1, which is the score 3.5, it's lower risk. If it's 4 and 4.5, it's higher risk. However, I think one of the most important developments in 2022 was the approval, or not the approval, sorry, the introduction and the publication of the International Prognostic Scoring System, the molecular one, the IPSSM. And you can see the model fit here in this slide using Cook's multivariable regression model, which was adjusted for confounders. Importantly, what you can see here is that the end result is that you are using 31 different genes. So you are using 31 different genes. 16 of them are called main effect genes, and the other 15 are called residual genes. So the residual genes are integrated all together to get you one genetic variable based on the number of mutations, while the other 16 main effect genes are weighed differently. You can see the different weighing in this busy figure. And I think very important finding within this system is that the ANC, the absolute neutrophil count, does not matter when you account for molecular alterations. So it's not part of the calculation for the IPSSM. However, the maroblast, platelet, and hemoglobin continue to be included, and the revised IPSS cytogenetic risk groups continue to be used. And luckily, you don't have to remember all of this because it's very difficult to calculate by hand. So there's actually an online calculator. You can see it on the left lower hand, the mdsriskmodel.com. This is a very useful calculator. I have used it multiple times, and since the publication of this paper, and it's relatively easy. It takes 2 to 3 minutes to actually calculate the risk score for a particular patient. And you can see, compared to the revised IPSS, the molecular IPSS gives you 6 groups. You have 6 different groups. And that's important because you don't have to deal with the intermediate risk group right now. Is it lower risk or higher risk? So now you have very low, low, or moderate low, and those are considered lower risk. And indeed, the overall survival for those patients together is more than 6 years. While those with the higher risk categories, which are the moderate, high, high, and very high, have a median overall survival of 1.5 years. And importantly, when you use the revised IPSS and then re-stratify patients according to the IPSS-M, almost half of the patients are risk stratified. So significant number of patients have different prognostic estimation, again, showing the importance of using molecular data. Now, since the publication, a number of papers have tried to replicate the validity of this model in a number of real-life analysis and large databases. I think one of the most important ones, which was published in ASH in an oral session, or presented in ASH in oral session, used the GenomeD for All database. And again, I'm showing you here one slide summarizing the top data results from this abstract. So this is a European database of more than 21 countries, more than 2,000 patients. All of them are molecularly annotated, and there is data regarding the outcomes and the treatments. And what you can see to the left is that the C index. So the C index is a measure of the prognostic utility of the model, or what we call the fitness of the model. Generally, anything more than 0.7 is good, and anything more than 0.8 is strong. And you can see here that the overall cohort of the study, that the C index for the molecular IPSS was 0.81, which was better than the revised IPSS, which was 0.74. So the revised IPSS still works okay. I mean, 0.74 is a good fitness of the model, but molecular integration clearly leads to better results, as you can see, to 0.81, and that's for overall survival. For leukemia-free survival, which is to the left lower side of the screen, it's even better, where you can see it's 0.76 for the revised IPSS, but almost 0.9 for the C index for the molecular IPSS. And I think one interesting finding is that even patients who do not have detectable molecular IPSS alterations, this model, the molecular IPSS, seemed to work better than the revised IPSS. And I don't have a good explanation for this. It could be related to the use of the blood counts and the platelet count as a continuous variable rather than categorical classification as in the revised IPSS. And this is another abstract that was presented in ASH using the baseline characteristics and the molecular alterations for almost 650 patients who were enrolled in 2 large studies, the Stimulus MDS1 and Stimulus MDS2. And this does not have correlation data with survival because these data are not available yet from the randomized phase 3 study. However, what I think is important, and you can quickly visually see that, is that as you reclassify patients and integrate molecular alterations in the IPSS-M, you can see the red part, which is a very high risk, is significantly bigger than the IPSS-R and the IPSS. And I think that is what we are seeing in reality, is that more and more patients are being upstaged. So more patients are upstaged and have higher risk categories when you account for molecular alterations. And clearly this has important implications for treatment. Some patients can be downstage, but generally this is a minority of patients. Most of the changes are upstaging. And this is an example of how does the output of this risk calculator, the online calculator, which again, you can see the website to the left, looks like. So you put in the molecular alterations, and by the way, you don't have to have all the gene abnormalities. You can put whatever you have, and the model is designed in a way to account for missing variables. And you can see the output is very nice. It gives you, and you can see to the top here, the platelet count, the hemoglobin. You enter all of this data, and then you can see that the IPSS-M score here is moderate high. Any positive result is generally considered high risk disease. Here it's moderate high. And you can see the leukemia-free survival is 2.3 years, and the overall survival is 2.8 years. But importantly, in addition to the IPSS-M, this can give you the IPSS-R score as well. So you don't have to worry about calculating both of them. Once you enter the data here, you can have both of those readings. And I think this is a nice printout that you can give to your patient on the initial visit to give them a kind of a sense of their prognosis in a visual way. So now that we talked about classifications, we talked about prognosis, the next item, I think, is the management. And I'll start with lower risk MDS. This is the current treatment paradigm for anemic patients with lower risk MDS. Most of those patients will receive ESAs, erythropoiesis stimulating agents. If they have deletion 5q, we typically will use either ESA or lenalidomide. And for patients who have higher risk disease, generally you will use hypomethylating agents or bone marrow transplant. Now, after ESA failure for lower risk disease in patients who have ring sideroblast, we have an approval in the year 2022 in the US for luspatercept, which I will talk about later. But this ASH has a number of, I think, important updates in the management of MDS, especially lower risk, that I think are worthy of discussion. So as a reminder, lenalidomide is currently approved for patients who have transfusion dependence. So those are patients who have severe anemia, needing regular transfusions, and with deletion 5q, lower risk MDS. You can see to the right that the transfusion independence rate is more than 60%. Almost 2/3 of patients will become transfusion independent. To the left, you can see that even among patients who do not have deletion 5q but have lower risk MDS and transfusion dependence, you can still get some responses. It's only around a quarter of patients with lenalidomide. However, the median duration is much shorter. It's in deletion 5q, it's more than 2 years. In non-deletion 5q, it's only around 30 weeks. However, I think there are many patients who are symptomatic from anemia, but they are not needing transfusion regularly. Their hemoglobins are like, let's say, 10 or 11. And there has been always a question whether to treat these patients. And I think one important presentation from ASH 2022 was the Central Rift trial, which basically randomized patients who have deletion 5q lower risk MDS, but were not yet transfusion dependent. So the hemoglobin has to be less than 12, and the patient had to be symptomatic from the anemia, but they were not needing regular transfusions. And you can see the patients were randomized to receive either lenalidomide at a small dose, 5 milligrams per day continuously. And important, this is only time-limited therapy, meaning it's given only for 2 years versus placebo. And 60 patients were randomized in total. You can see the baseline characteristics to the right in the table, very typical for your patients with deletion 5q. And what the authors found is that the primary endpoint, which is the time to transfusion dependency, was much longer, much longer basically with lenalidomide, meaning that the patients who received lenalidomide were able to stay in a period where they are not needing regular transfusions. It's not reached at the cutoff, the final cutoff of the data, but it's more than 6 years based on the median follow-up compared to 11 months with placebo. And the number of patients who needed transfusions during the study follow-up also is much lower in patients who received placebo, with a significant hazard ratio reduction. The len reduced the risk of transfusion dependence by almost 70%. And there were cytogenic responses. Most of those patients who received lenalidomide have cleared their deletion 5q. And you can see here for when it comes to the safety that, as expected, more side effects with lenalidomide. However, most of them were grade 1 and grade 2, not grade 3 or 4, and generally were reversible. And importantly, there was no increased risk of progression to leukemia. And there was, as expected, some thrombocytopenia and neutropenia with lenalidomide more than placebo. However, generally, it was not clinically relevant and it was reversible. And there was no difference in overall survival, which the study was not powered or measured to look at. And lastly, among patients who have TP53, which we have a theoretical concern about using lenalidomide because preclinical data suggested that lenalidomide can lead to expansion of the TP53 clones on those patients. This was not seen in this study. However, as you can see to the right lower part of the slide, that this was a small number of patients, only 5 and 6 patients had the TP53, and there was no difference in progression to AML or in the risk of TP53 expansion. So I think this is a very intriguing study because it certainly warrants the consideration of treating patients with deletion 5q lower risk MDS who are anemic but are not yet transfusion dependent. And I think it's important, though, to consider whether they have TP53 mutation, because I think this is an area that I think needs further data about early initiation of therapy. Moving from lenalidomide to luspatercept, I mentioned that this is a transforming growth factor inhibitor. This basically is a ligand trap. You can see the structure of the drug luspatercept. It has a part of the human IgG1 Fc domain, which is linked to a modified extracellular domain of the activin receptor 2 beta. And this will remove the ligands of this pathway, which have been shown to suppress erythropoiesis, especially late stages of erythropoiesis through SMAD signaling. And luspatercept was shown to reverse this process and restore erythropoiesis in patients with lower risk MDS who are transfusion dependent for patients who have ring sideroblast. And this, you can see to the left, the results of the MEDALIST trial, which showed that transfusion independence rate was 38% with luspatercept compared to 13%, and the median duration was around 32 weeks with this treatment. Based on this, the FDA approved the drug. We recently published last year a longer-term follow-up of this trial, also showing sustained benefit, but also importantly, a significant reduction in transfusion burden and significant improvement in the HIE, hematologic improvement in the erythroid lineage. So benefits beyond the transfusion independence. The rate of transfusion independence that I showed you does not fully capture the benefits of luspatercept. As you can see, many patients will achieve hematologic improvement, almost 60%, as well as the ones who are still needing transfusions. Many of them will have a significant reduction in the total number of units they need, including among patients who have high transfusion burden. And based on the MEDALIST trial, the COMMANDS trial was initiated. So this is trying to move luspatercept to the frontline setting. And this trial enrolls patients with lower risk MDS patients who are transfusion dependent, who, regardless whether they have ring sideroblast or not. Remember, luspatercept is approved for patients with ring sideroblast. And patients were randomized in 1-to-1 fashion to receive either luspatercept or ESA, which is the standard of care. And the patients were followed up for transfusion independence at 12 weeks as the primary endpoint of the study. Now, this study was not presented in ASH. The COMMANDS was not yet presented. The reason why I'm showing you is that this company has announced the top-line results that the study met its primary endpoint, which, as I mentioned, is transfusion independence at 12 weeks. And I think this is important because this is the first time we have something that improves transfusion dependence over ESA as a frontline treatment. Of course, we need to see the details of the study, which hopefully will be presented later this year. But depending on the FDA review of this study, this could lead to a change in the standard of care for frontline management of patients with MDS. So moving from luspatercept to immunosuppressive therapy, we and others have shown that immunosuppressive therapy with cyclosporine and ATG can help patients with MDS, especially those with lower risk disease and hypoplastic hypoplasia. You can see that the CR rate is 11%. This was a retrospective analysis. There have been a number of prospective studies as well. And this is, I think, an underused treatment option for lower risk MDS that can be considered, especially in cases where other treatment options have not worked. Another important drug that's being studied is imetelstat, which is a first-in-class telomerase inhibitor. Imetelstat basically is a direct and competitive inhibitor and has a disease-modifying potential basically by killing the malignant stem cells and allowing recovery of erythropoiesis. And it has shown nice preclinical data. A phase 2 single-arm study was already done and published in JCO a couple of years ago now that showed that the use of this drug, which is given intravenously every 4 weeks can lead to significant transfusion independence. So among the 38 patients enrolled on that study who had heavy transfusion needs and had non-deletion 5q lower risk MDS, but were not previously treated with HMA or lenalidomide, the transfusion independence rate was 40%. So this was already published. What was presented in ASH 2022 was an update on the 29 patients, on the 11 patients, which is 29%. You can see in the middle row that had transfusion independence that lasted for more than a year. And I think it was impressive to see that those patients continue to be in sustained transfusion independence. The median transfusion dependence was 93 weeks. The median rise in the hemoglobin was almost, or the mean hemoglobin increase was 3 grams, more than 3 grams, which again is quite impressive. So I think this sparked a lot of interest in this drug. The randomized phase 3 study, the Amer, was also completed accrual and was not presented at ASH, but I think what is important is that the data has been released in a press release, basically by the sponsor in early 2023, showing that the phase 2 results were replicated in the transfusion independence rate at 8 weeks, which is the primary endpoint of the phase 3 portion, with 40% transfusion independence, with a, I think, quite nice prolonged transfusion independence duration at 52 weeks, and a significant median rise in the hemoglobin among responders of 3.6 grams. So I think in all fronts, the data, this is only a press release, so we have to see the full data, which hopefully will be presented later this year. But again, depending on the regulatory review and action, this drug could also become one of the standard of care options in the relapsed refractory in the relapsed refractory lower risk MDS after ESA patients, and this is regardless if we have ring sideroblast or not. So I think we are waiting for the presentation of both the COMMANDS and the Amer studies and see the regulatory action on both of those agents and see how lower risk MDS will continue to evolve in terms of its treatment landscape. Another option for lower risk MDS continues to be the use of low dose azacitidine and decitabine. This data has been pioneered by the MD Anderson group. There was a recent update in the New England Journal of Medicine in 2022 showing transfusion dependence of 20 to 40% with either drug. But I think the impressive part to me was the median duration transfusion independence was 22 months. So almost 2 years, which is quite impressive. So this is another option that we consider. This is 3 days of decitabine or 3 days of azacitidine. Of course, now we have oral hypomethylating agents. Many of you are familiar with this drug, sidazolidine decitabine. So decitabine cannot be taken orally because it gets metabolized by cytidine deaminase. Sidazolidine is an inhibitor of the cytidine deaminase, and therefore, when sidazolidine was added to decitabine and used as an oral treatment, it had pharmacokinetic equivalence, which was shown in the phase 3 trial called the Ascertain, and that led to approval for patients with higher risk MDS as an alternative to hypomethylating agents. However, there has been an interest in studying this in lower risk MDS, and this is, I think, an important study that was presented in ASH 2022, looking at lower doses of oral decitabine, where patients received, you can see the doses. It's a complex kind of dose escalation schema. However, what I think is important to note that decitabine was used at lower doses, so the approved dose is 35 milligram with the sidazolidine 100 milligrams. So they used, instead of 35, they used 5 milligram, 10 milligram, 15 milligram. They were used for 5 days, 7 days, 10 days. And the primary endpoint was the safety in terms of inducing neutropenia and infections, as well as the secondary endpoints about the HI, the hematologic improvement. And I would point your attention to cohort B1, which is in orange. You can see that the dose, this is the dose that was selected for the next part of the study. So this was a 10 milligram of decitabine given for 5 days. And again, this is an oral pill. And you can see that the transfusion independence was 57%. So it's a small cohort of patients, but among those who are transfusion dependent, 57% of them responded. And again, I think this is impressive, but it's a small number of patients. And the ongoing second part of the study, which is a randomized part using this dose against a 3-day course of the approved dose. And I think between these two, we are going to know, I think, the better dose to use in patients with the lower risk MDS. And importantly, there was neutropenia as expected because you are using an HMA, but generally it was modified, it was reversible with dose interruption. And there was basically, I think generally the safety data were good on this study. Moving in the last 10 minutes or so to higher risk MDS. So as many of you know, standard treatment is hypomethylating agents, azacitidine or decitabine. However, the outcomes in multiple real-life analyses, I'm showing you 3 of the studies that we have done, showing that among SEER Medicare patients, so those are older than 65, among patients treated in big centers, such as the MDS Clinical Research Consortium, and lastly, among even patients included in clinical trials in a pooled analysis, the median OS is somewhere between 11 to 19 months. It's much shorter than the 24 months than was shown in the original ASA001 study that led to approval. And because of that, there has been an interest in building on HMAs by adding another drug, so HMA combinations. However, unfortunately, we have a big graveyard of combinations, drugs that were added to hypomethylating agents that showed nice phase 2 data, but once you have gone to the phase 3, the results were not different. So currently, you can see some of those drugs listed. None of those have been shown to improve overall survival over HMA monotherapy when tested in randomized clinical trials. There are multiple reasons for that. I think for the reasons of time limitations, I'm not going to go into a lot of this, but I think one important issue in drug development in MDS is the IWG response criteria has significant limitations. For example, to count as a complete remission, the hemoglobin has to go all the way up to 11, which is very difficult to achieve in many patients, especially with ongoing therapy with myelosuppressive agents. Also, I think those criteria have led to reporting promising results for patients who achieve marrow CR. But we know marrow CR has not been correlated with long-term survival. And as a result of this, after almost 15 years of using these criteria, finally the IWG criteria was updated. This is the IWG 2023. This was just published in Blood, and I encourage you to go and look at the differences. We have, I think, provided a lot of explanations about the rationale of those changes, which were made on consensus basis. And I do think they are going to help improving the quality of reporting from clinical trials so that the endpoints are more reflective of clinical benefit to patients and hopefully can correlate to long-term outcomes in a better way than the IWG 2006. We know that in MDS, the standard of care for patients who can undergo transplant is going through transplant. However, it's a minority of patients. One question that commonly comes is if the patient doesn't want to go to transplant, what's their outcome? Here we are showing you a real-life analysis published in Blood that for patients who respond to HMAs but do not go to transplant, the long-term survival is only 4%. So it's negligible. Almost all patients will die without a bone marrow transplant. And this is why we strongly remind people that transplant should be always considered, and not only for younger patients. This is a very important study published in Journal of Clinical Oncology. There were 2 studies, one from Europe and one from the US. Both of them suggested that in biologic assignment trials, and this is the closest you can get in to a randomized study in the transplant setting, up to the age of 75. So you can look not only at 50, 60, 70, but up to the age of 75, patients who had a donor and went to transplant had a survival of 50% at 3 years compared to 25% for those who did not have a donor and did not undergo transplant. So almost double the survival. So I think it's very important to tell your patients and consider them for transplant, because until now we are seeing patients in their even 60s who are being told by their local doctors that they are not candidates for transplant. I mentioned to you that a certain study led to the approval of decitabine and cedazoridine. So this drug is now used, and we have seen regular updates from the phase 3 trial that led to the approval of the drug. This is the last update. Hopefully the data will be published soon so that the community can see the full data. Other drugs that are being tested in phase 3 trials, which we are hoping they are going to have a better result than the previously failed phase 3 trials that I showed you some of. Venetoclax is a very exciting PCL2 oral inhibitor. In a phase 2 trial, a large phase 2 trial has shown the overall response rate to be around 80%, the complete response around 35%, and this was across molecular alterations, including TP53, which generally does not respond very well to therapies. And we have shown in the relapse refractory setting, this is a paper that was just published in the American Journal of Hematology now, if you want to go and look at the details. But for patients who have HMA failure, adding venetoclax to azacitidine has led to responses, not only in terms of achieving CR and marrow CR in around 39% of patients, but most of those marrow CRs, as I mentioned, marrow CR by itself is not a good response. But once you have marrow CR with hematologic improvement, that's clinically meaningful. So you can see 6 patients achieve marrow CR with HI, which is around half of the patients who achieve marrow CR. And almost half of the patients achieve transfusion independence to blood or platelets. So I think important, meaningful clinical benefits. And this is one option I consider off-label for my patients who have high-risk MDS after HMA failure, especially if they are unable to go to transplant. But clearly, you have to counsel the patients about the infectious complications, and important to monitor the blood counts, drug reactions, important to do bone marrows and hold the venetoclax to allow count recovery. All of these things that we do in AML are similarly done in MDS. And importantly, venetoclax in MDS trials is given only for 40 days, 14, compared to AML, where the approval is with continuous dosing. So the Verona study is a large randomized phase 3 trial that is looking at this issue of treatment with AZA versus AZA-VEN, and will give us the definitive answer. I went over the considerations in the use of venetoclax. CPX, or liposomal daunorubicin cytarabine, is approved in AML, but secondary AML, but not in MDS. However, results from selected cohorts of patients, younger patients who are fit for intensive chemo, many of them went to transplant, seem to do okay. So I think this is one option. Immune checkpoint inhibition, this is an area that I've done a lot of work on personally. The results so far have not been overwhelming. You can see that there was no improvement in the only randomized phase study in high-risk MDS using an immune checkpoint inhibitor, PD-L1 durvalumab, where there was no improvement in overall response rate or survival. However, some of the newer novel immune checkpoint inhibitors, such as sabatolimab and magrolimab, appear to be more promising. TIM3 is an inhibitory receptor not only present on T cells, but also on innate immune cells, as well as the leukemia stem cells and the leukemia blasts. And the use of this antibody not only acts as an immune checkpoint inhibitor, but potentially can directly target the leukemia cells. Nice preclinical data and early phase data led to a randomized study, the Stimulus MDS-1. This is a randomized phase 2 study conducted in 17 countries, more than 47 centers, adult patients with high-risk MDS. And the patients were randomized to receive azacitidine or decitabine at the choice of the physician, plus minus sabatolimab. The primary endpoint was CR, or progression-free survival. The primary endpoint of this study was not met. It was not statistically significant. You can see that the CR rate was 21% compared to 18%. And the progression-free survival, while it was not statistically significant, you can see it was 11 months compared to 8.5 months. However, when you look at the curves for the PFS, you can see a late separation. And this is, I think, is interesting because immune checkpoint inhibition certainly can have delayed onset of benefit. And also among those who achieved complete response, the patients who got sabatolimab with HMA compared to HMA alone had a longer duration of response, 18 months compared to 9 months, raising the question of whether sabatolimab is deepening the response among those who respond. Of course, the study was overall negative in terms of the primary endpoint. However, I think with the evidence of delayed benefit, especially in patients who have lower disease burden, I think we are waiting for the results of the randomized phase 3 study of sabatolimab with AZA versus AZA alone. This is a study that is fully accrued. More than 500 patients have been enrolled, and we are waiting for the results, which probably will come in early 2024. Magrolimab, the anti-CD47, works on don't eat me signal pathway to activate the macrophages against the leukemia blast. Also had nice data in early phase clinical trials, in single arm trials. And I think this is going to be also important to see the results of the enhanced randomized studies. This is a study that enrolled patients to receive AZA-magro versus AZA alone. It's fully enrolled as well, and we are waiting to see the results. IDH inhibitors, inacitinib and ivosidenib, you can see both of them. Those mutations don't happen often in MDS patients, but when the patients have them, they seem to respond to HMAs. So I certainly check for them, especially after HMA failure. And however, you have to monitor for the same risks, such as the differentiation syndrome that you can see in patients with AML. And clearly, this is off-label use compared to AML, where the drug is approved. So you can see here in this table 4 randomized clinical trials that are ongoing: venetoclax, sabatolimab, magrolimab, and tamibarotene, which is a RARA agonist. And then the ones in black, pivonidistat and APR246, are unfortunately phase 3 trials that already reported as negative. And HMA failure continues to be a setting where it's very challenging to treat patients, no approved treatment. So we always consider clinical trials whenever possible for those patients. And there's a large number of clinical trials that are being actively enrolling, and hopefully we are going to see a major difference in outcomes of patients, both in the frontline and the HMA failure setting in the next few years. So this was my last slide. These are my acknowledgements for my funding organizations, and again, my email and my Twitter handle, and feel free to reach out to me for any questions. Thank you so much.